Hi everyone, this week we're going to be assigning AJCC and summary stage for melanoma of the skin or cutaneous melanomas. There are no updates or corrections needed to Chapter 47. Only cutaneous melanomas, melanomas of the skin, are staged using this chapter. The list of histologies is provided on page 565. But keep in mind, non-cutaneous melanomas, melanomas of the conjunctiva, uvea, head and neck, urethra, vagina, rectum, and anus do not use this chapter. Then we also have Merkel cell carcinoma and squamous cell carcinoma of the skin that are not staged using this chapter. They have their own chapters to stage that type of histology. So keep in mind that this chapter is for melanomas only and only cutaneous melanomas. To assign the clinical stage for cutaneous melanoma, it's the same basically as all other sites. We use the history and physical, specifically the exam of that lesion and any lymph nodes in the region or area of the body where that lesion is, and the biopsy, which may include an excisional biopsy. Remember, excisional biopsy is when they remove the entire lesion. Now, if the first biopsy that is performed on this lesion that proves melanoma is an excisional biopsy, then we use that information from that excisional biopsy for assigning the clinical stage, okay? Even though it may remove the entire lesion, it's still, if it's the first biopsy that proves this lesion to be melanoma, then we use that information to clinically stage it. Imaging, which is once again not required and is seldom done unless metastatic disease is suspected, is also used when assigning the clinical stage. Now, as you've heard many times already this semester, the pathological classification is used to guide adjuvant therapy and provides useful information to estimate prognosis and calculate end results. It is based on all clinical information and additional information acquired from surgery that the surgeon will document in the op report, and the examination of the resected specimen or specimens by the pathologist. To assign the PT, pathologic T category, a wide excision and or re-excision must be performed. Now, if that lesion is determined to be an in situ melanoma or a T1 lesion, lymph nodes are not required to be removed. So if that happens, if that's the case, we would assign a CN0 for the PN category. Okay, but if the lesion is a T2 or higher, then lymph nodes must be removed to assign the PN category. If lymph nodes are not removed, but the wide excision or re-excision identifies a T2 lesion or higher, then the PN must be assigned as PNX because the lymph nodes were not pathologically assessed. So once again, if you have a pathological T1 lesion or an in situ lesion, lymph nodes are not required to be removed by the surgeon. So then we would assign the pathologic T, whatever we have for our situation. But then if no lymph nodes were removed, then we assign a CN0 in the PN category, all right? Now, it's possible that neoadjuvant systemic treatment can be offered after the initial diagnosis and staging of regional lymph nodes by sentinel lymph node biopsy. So in other words, they diagnose that this person has melanoma and they do a sentinel lymph node biopsy before any additional surgery. And the patient actually goes on to have neoadjuvant therapy prior to that wide excision or re-excision. In that case, the information from the sentinel lymph node biopsy can be used to assign the CN category, okay? Why? Because that sentinel lymph node biopsy was done prior to treatment, okay? Prior to the pathological requirement of a wide excision or re-excision. If then the sentinel lymph node biopsy is done prior to that neoadjuvant therapy, we would assign a PN, whatever category we need to assign for our N category in the CN, the clinical classification field. So here is a situation where we can actually use a PN in the CN category. The T category for melanoma is classified primarily by measuring the thickness of the melanoma as defined by Dr. Breslow. So you may see this labeled as Breslow thickness. Note that the measurement is in millimeters. The second criteria for determining the T category is primary tumor ulceration. Both of these would be found on the biopsy pathology report. So this information you would get from the pathology report. The N category is based on the number of lymph nodes that are positive and whether these were clinically negative and microscopically positive or clinically and pathologically positive. Now, lymph nodes that are negative by clinical examination and imaging, if done, but are determined to be positive microscopically, are defined as clinically occult. So when you see the term clinically occult, that means that the patient's lymph nodes were clinically negative, but when the lymph node or nodes were removed and viewed under the microscope by the pathologist, there was cancer identified within the lymph node or lymph nodes. You will also note that there is an added column for the melanoma N category table. The presence or absence of microsatellite, satellite, or in-transit mets, regardless of the number of lesions, also represents an N category criterion. The pathology report will state if these are present or not. For our cases in class, if it does not state that there are any of these, then just assume there are none, okay? If your case has these present, I would state it in the case summary. So when you are assigning the N category, look for the number of positive lymph nodes, whether they were clinically positive or negative. Then go to the next column and find the yes or no for your subcategory. The M category has 4 subcategories, which are broken down into additional subcategories. As you can see, the additional information being used to assign the M1 subcategory is the LDH level. So, as we learned when assigning the melanoma SSTIs, the LDH is usually ordered for patients that have distant metastatic disease and is used then to assign the M1 subcategory. These subcategories may seem complicated at first, but it really isn't. Each subcategory has no to specify the exact type of distant mets that the patient has. So M1A is distant mets to the skin, soft tissue, which includes the muscle, and or non-regional lymph nodes. So if your patient has one or all of those, and that's the only metastatic disease that they have, then you would have an M1A subcategory. And then you would go on and go to the one, if there was LDH that was ordered and was performed. If it's negative, you would use the M1A0. If it was elevated or positive, you would assign the M1A1. All right. If there is no LDH recorded, that it was done, or you don't have that information, then you would assign the subcategory M1A and would not assign a subcategory. So then the M1B is distant mets to the lung, and this can be with or without any of the sites listed in M1A. M1C is distant mets to a non-CNS visceral site. Once again, with or without any site listed in M1A or M1B. M1D is distant mets to the CNS. Usually the CNS is the brain. And this is once again with or without any other site. Okay, so if your patient has melanoma and they only have distant metastatic disease to the brain, you would assign M1D and then the subcategory if possible. If the patient had distant metastatic disease to the lung only, you would assign an M1B and then the subcategory if the LDH was performed. All right, so if there are multiple, just find that one site that has the greatest, the highest M category, and then use that subcategory and then determine your subcategory with the LDH information. If you do not have that LDH level, don't know whether it was normal or elevated, then you just stick with the subcategory of your distant metastatic site. That seems complicated, I know, but thankfully, melanomas are caught pretty early. So hopefully you will not have to use the M category often when assigning and abstracting melanoma cases. Except for the factors that are used to assign the TN and the M categories, there aren't any additional prognostic factors that are required to assign the stage group for melanomas. Normally, melanoma of the skin is not graded. So AJCC manual does not list a preferred grade system to be used. So The generic registry grade system, the 4-grade, well, moderately, poorly, undifferentiated, the 4-grade system can be used if a grade is provided in the pathology report. But once again, it normally isn't graded because it's not required to be graded. It's not recommended to be graded. So, all right. So if you want to stop the presentation here, and there are once again 3 case studies for you to complete. All right, once you've gone through those, come back and watch part 2, and we'll go through the cases together.